All right, welcome back. We'll get started with our session 1. Hope everyone had a chance to get caffeinated. So I'm Stacey Sigmon. I'm a professor here at the University of Vermont, and I'll be chairing this morning's session. And it's entitled Tobacco Product Use and Cessation Among People with Comorbid Substance Use. And we have 3 presentations lined up. Our first presenter will be Dr. Lisa Fucito. Dr. Fucito is a licensed clinical psychologist and an associate professor of psychiatry at the Yale University School of Medicine. She is also the director of the Tobacco Treatment Service at the Smilow Cancer Hospital there. And she is an expert in the assessment and treatment of tobacco use and specializes in vulnerable subpopulations with comorbid psychiatric and medical conditions. So I'd like to welcome Dr. Fucito up now, and the title of her talk this morning is Tobacco Product Use and At-Risk Drinking, Integrated Treatment Strategies and Emerging Trends. Welcome.
Hey, good morning, everybody, and thank you so much to Stacey and Eli and others who invited me to participate. Okay, just to start off, these are my disclosures. I have received paid consultation for serving on an advisory board for a pharmaceutical company. I've received NIH grant support, and unrelated to this work, I filed intellectual property that's related to digital interventions. Okay, so let's start off with alcohol use epidemiology. I'm sure you're all very familiar with this, but just as a reminder, alcohol use is very common in the United States. And I don't know if anybody realized this, but apparently Vermont gets the award for having the most breweries per capita of any state. So if you haven't had a chance to take up that opportunity, just wanted to share that little tidbit that I learned about Vermont. So more than half of US adults drink, and more than a quarter drink at heavy or binge levels. And again, for those of you who may not be familiar, we define binge drinking, at least in the United States, as for women drinking 4 or more drinks on an occasion, and for men drinking 5 or more drinks on an occasion. So about a quarter drink at those heavy levels. And in 2023, more than 8% of Americans ages 12 and older met criteria for an alcohol use disorder. So again, this statistic is probably well known by all of you, but cigarette smoking has reached its all-time low in the United States. About 11.5% of US adults smoke, and this represents nearly a 75% decrease since the first US Surgeon General's report on the negative health consequences of smoking in 1965. So this is a huge decrease. But the overall prevalence of tobacco use is closer to about 20%. That's still best accounted for by cigarette smoking, but again, overall tobacco product use is still pretty high. And importantly, e-cigarette use is really on track to overtake cigarette smoking as the predominant form of tobacco use. So I just want to highlight, this is a recent article that was led by Brandon Sanford at the Medical University of South Carolina. And they were using the national surveillance data, the PATH survey, to really look at rates of established cigarette smoking and rates of established vaping, particularly among young people ages 18 to 24. So if you look at the bottom figure, it starts off with the PATH data in wave 1, which is, it's hard to see, but it's about 2013. And you can see the combination bars basically at the bottom represent the combined established use of smoking or established vaping. So from about 2013 to the most recent wave, which is about 2021, the rates have been pretty similar. But the story, I think, gets a lot more interesting when you look at the top figure. So that's breaking the columns up by established cigarette smoking, established vaping. And again, it's a little bit hard to see, but so those black or those dark columns represent established cigarette smoking. The white ones represent, they're actually supposed to be light gray, but I don't think they're showing up. The lighter gray ones represent established vaping among people with a cigarette smoking history. And then the tinier columns represent people who have established vaping who never had a cigarette smoking history. And right about 2018, you start to see in young people vaping overtook cigarette smoking. And since we know that most of these behaviors are established in young during young adulthood or adolescence. We believe we're sort of on track now for this to overtake cigarette smoking in the future, which is why the work that Nancy just presented is really important, because that's going to be what we're going to be treating over the next few decades. Okay, so what do we observe when we talk about both behaviors together? Well, rates of heavy drinking tend to be higher among people who smoke compared to people who don't smoke. The rates are estimated to be about 20% compared to those who don't smoke. And likewise, smoking rates are 2 to 3 times higher in those who drink heavily. So this is actually a paper led by Andrea Weinberger, and it was using data from the National Survey on Drug Use and Health. And it started off looking at data from 2002 up to about 2016. And what you see at the bottom is basically the smoking rates for people without an alcohol use disorder. So that's that black line that's going across. And all the other lines above it are people who have an alcohol use disorder. And so much higher rates, as you can see, but also they go up exponentially by alcohol use severity. So the more severe your alcohol use disorder is, the greater your smoking rates. So these are quite dramatic differences in smoking rates among those people who drink heavily. We also observe strong associations between these behaviors and smokeless tobacco. Oh, I've skipped ahead. So a reason why we're very concerned about these behaviors is that they tend to be associated with pretty significant health consequences. So in particular, they tend to have synergistic effects for certain cancers. They're associated with increased cardiovascular risk, so increased risk of having hypertension, heart disease, as well as multiple domains of neurocognitive dysfunction. And people who engage in both of these behaviors tend to have multi-morbidities. So they tend to have other health issues. They tend to have other mental health concerns. They tend to have other substance use, cannabis being one of the most common ones. And they tend to have increased rates of homelessness. So they're a very tough group to treat, because where do you start, right? They have multiple things that they present with. And unfortunately, these behaviors, if they are treated, they tend to be treated separately. So you go over here for alcohol, you go over here for tobacco. They tend to not be integrated. And for a long time, that was largely due to the misperception, especially in a lot of addiction treatment centers, that if you target someone smoking, you're going to put them at risk for not having a good alcohol recovery. And basically, by trying to focus on that, you were going to put their alcohol use recovery at risk. And really, the data has not come out to support that. And this was a meta-analysis that Jody Petraska conducted almost about a decade ago, 2 decades ago. It's amazing how long ago that was. But really what the take-home message of that research was that it either had no impact on your drinking outcomes, or it actually was associated with improved alcohol recovery. But by and large, what we see is that individuals who report both of these behaviors tend to have greater difficulty initiating smoking abstinence and sustaining it, and similarly tend to have greater difficulty moderating their drinking or abstaining. And so I think it's important to highlight that the US tobacco treatment guidelines actually have information about alcohol in there as a suggested factor that should be covered. So this is specifically taken from the practice guidelines. It says, because alcohol is associated with relapse, the patient should consider limiting or abstaining from alcohol while quitting. Of course, this is very vague. It doesn't give you really any guidance of exactly how to do this. So we don't really know routinely how often this is being done, but this is an important risk factor that's supposed to be addressed. So we have further challenges. So a lot of that work I was presenting is older research, right? Now we have new products, and we really are starting to see that this association between alcohol and nicotine is continuing now with these other products. So there's a meta-analysis that I wanted to just highlight at the bottom here, and the results suggest that among young people who use e-cigarettes, the rates of drinking are 6 times higher, and the rates of heavy drinking are 6 times higher than those who don't use e-cigarettes. And these are nicotine pouches, as you know, on the other side. And though that research that's coming out is very new about those products, and we don't really know enough yet about how those may be related to alcohol, at least in some of the young adult studies that we're conducting related to alcohol, we are seeing young people reporting that they're using pouches around occasions of drinking. My colleague Grace Kong and I were just talking about this last night, and there could be this potential, she's finding it in some of her qualitative work, that maybe using pouches might potentially be protective, but more research needs to be done. So I think this is an interesting space to see how pouches might be related to drinking. Social media, also a newer thing that really, I think, further complicates this area. So what we see from social media is that it's really contributing to co-use because it's really normalizing or glamorizing use. It's spreading misinformation and really downplaying the risks of using both of these. And we know there's multiple sources for that, right? It could be industry, influencers, or peers. And so in preparation for this talk, I tried to just do a little bit of a search of, what's out there, especially about pouches. And so there was some Reddit posts where they're soliciting feedback about what are the best combinations of pouches that you can use with different drinks. Apparently apple cider with wintergreen is a good one. And also just a website that was kind of encouraging that you should use alcohol with pouches because you'd get a better experience. And also, this is this really interesting study that was conducted by Alex Russell and colleagues that was looking at an analysis of tweet posts. And so what they found was that the great majority that they analyzed really were in favor of the co-use. And I think that's best exemplified by that quote that's in the article, in the title, "Can someone tell me why nicotine is so fire when you're drunk?" So again, this is a newer space when we look at e-cigarettes and pouches, but we were interested in trying to understand, well, how might alcohol use be related to tobacco use in young people? And so I do digital health interventions for alcohol in young people in one of my other hats that I wear. And so my current postdoc, Oksana Ellison, has been conducting secondary analyses of these trials to really understand how these behaviors may go together. So in this one study of individuals who had young people ages 18 to 25 who had to report recent heavy drinking in the past 2 weeks, we found that a third of them reported Juul use at baseline. So she was interested in asking the question, well, how did those who report Juul use, Juul, not dual use, Juul, I have to say that more clearly, how did they differ from those who didn't? And so not surprisingly, they were reporting greater drinking, greater alcohol-related consequences, increased likelihood of meeting criteria for an alcohol use disorder, but again, additional consequences. So these people already drink heavily, and it was separating out the heavies from already people who drink heavily. They were also reporting greater ratings of sleep disturbance and greater difficulties with their sleep as measured by an objective device, an actigraph that measures how efficient your sleep is. And what about the effect of alcohol on e-cigarette cessation? So we recently completed a placebo-controlled trial of varenicline for e-cigarette cessation in adults. This was a sample of 40 people, and it was conducted by myself and Ben Toll at the Medical University of South Carolina. We did see an effect of varenicline versus placebo on overall quitting. But in preparation for this talk, I was interested in figuring out, well, how might alcohol use be related to success at quitting e-cigarettes? This was a sample of people who reported primary e-cigarette use. Average age was about 28, and we did allow people to have a cigarette smoking history. And so I just looked at the Yale subsite because we have a lot of data and that we're still cleaning. And I would say our site study data was a little bit cleaner. So I said, Ben, I'm not touching your side yet. And so I looked at just the 20 people on our side what their outcomes were like. So this is the primary outcome, which was point prevalence abstinence at 8 weeks. We did a shorter treatment period because this was a preliminary study. And so what you see here was there was a significant difference for those who quit versus those who didn't quit. Those who were unable to achieve e-cigarette cessation reported significantly higher drinking than those who did not. So again, I think these problems are just transitioning now to these new products. So why do we see these potential associations? There's a number of different factors that are associated, right? So we do know from a well-established literature on, especially from preclinical and lab data, that both of these substances, these drugs, potentiate the effects of each other. So if you use nicotine while you're drinking, you're not going to feel so impaired, right? And we also know that alcohol potentiates the rewarding effects of nicotine. So because of that, through conditioning, they can serve as a motivator for the other. They also tend to accompany similar risk factors that we know are predictive of having substance use problems. They also tend to happen in social environments that expose you to people using, and they have overlapping pharmacological actions at the molecular level, specifically the acetylcholine and endogenous opioid systems. So related to these mechanisms, we conducted some studies to try to understand, what might predict why someone doesn't do as well when they try to quit smoking related to their alcohol consumption status. And this is an old paper now of a trial conducted by Tim Baker, where they were able to get 1,500 people to participate in a smoking cessation trial. Those people in Wisconsin, they could just conduct these amazingly large trials. And this was a secondary analysis led by Jessica Cook. And so we looked at alcohol consumption status as a predictor of different milestones. So I'm just going to try to breeze through this because I see I'm already running out of time. So we compared people who reported binge drinking to those who were moderate drinkers, as well as those who were non or infrequent drinkers. And what we saw was that they were significantly less likely, the binge drinkers in particular, were significantly less likely to achieve initial cessation, and they were also significantly more likely to lapse. And then we thought, well, why is that? So we looked at some of the measures that they completed. They completed the FT&D, they completed the Wisdom, which is a measure of smoking motives. And we also asked them about the number of smokers in their environment. And what pulled out for the people who binge drink is that they scored higher on these secondary motives of nicotine dependence. So they're more cued by their environment and their routines to smoke. And they tend to be more around people who are smoking, and they had higher numbers of people in their environment or their network who smoke. So again, breezing through this because now I haven't even gotten to the integrated treatment strategies. So given all these challenges, what can we do? Well, we can try to integrate treatment, right? And we can do that a few ways. We could try to take a medication that might have a benefit on both. We could try to take a behavioral intervention that might be helpful for one and put it in the other, or we can maybe take some transdiagnostic approach. So this was, again, a study a long time ago that where when Chantix first came out, there was some lab data that started to suggest that it potentially could have a benefit for alcohol. So we conducted one of the preliminary studies to test that out. And what we did was we took people who wanted smoking cessation treatment but reported heavy alcohol use, and we brought them in and we randomly assigned them to this placebo-controlled phase followed by an open label phase. So during this 3-week phase, they would get either placebo or varenicline followed by an open label phase. And during that initial period prior to a smoking quit date, we didn't tell them anything about their drinking, but we then advised them right before their quit date per the tobacco guidelines to consider abstaining or moderating from drinking. And what we found was that the varenicline group that had that active pretreatment had significantly lower alcohol cravings and numerically greater reductions in heavy drinking. And importantly, the quit rate in this group overall was 43%, which is a pretty huge quit rate among a group of people who meet criteria for alcohol use disorder. We did follow up this study in a larger trial specifically for the treatment of alcohol use disorder. And I'll cut to the punchline that it generally wasn't that great in terms of the effects on alcohol. We had an effect for men, but not for women. But also importantly, we showed a quit rate of 13% versus 0 for placebo. And I just want to highlight that when you take people in who are specifically looking for alcohol treatment and you don't really target smoking, you're not, even if you have an effective medication, you're not generally going to get a very high smoking quit rate. I'm already sort of out of time, so I just want to highlight this was a quitline study that I was participating in with Ben Toll. This was basically, could you train quitline specialists to provide a brief alcohol intervention at the time when quitline callers were calling? And then basically what we were able to find was that the integrated group did better. They had a higher quit rate, and they tended to have better drinking outcomes. So for my career development award, I tried to do an integrated transdiagnostic approach where I basically recruited people who reported either behavior and then said, okay, based on either behavior, we recruited them in and said what is the primary behavior that you would like to work on? And then we randomly assigned them either to single treatment based on their primary concern or an integrated treatment strategy. And they also received varenicline because at the time there was promising data that suggested it would be helpful. Again, I'm kind of out of time, but basically the take home was that it was hard to retain this group in treatment. More adults sought help for their tobacco use than their drinking. We did have an overall quit rate of about 35%, and twice as many people in the integrated group quit smoking than in the single group. But this effect was only observed in men, and women just generally didn't do as well in the study. And both groups significantly reduced over time. So just some conclusions and next steps. I think tobacco treatment is an opportunity to engage people about their drinking. I think they probably need more help for their drinking, something like naltrexone. Televideo offers a lot of solutions for this population. And transdiagnostic content that we use was largely focused on social factors and reducing exposure to cues. And I think probably that could be improved upon. And I think this needs to be expanded to other forms of tobacco use. These are just some examples of other studies in this space where they've shown that varenicline plus patch might be better for this population. Varenicline plus naltrexone might be particularly better for drinking. There's also some interesting mindfulness-based studies and Facebook integrated interventions. But last, I think it's important to highlight that policy is really needed to make population impact changes for this issue. Amazingly, the ban on smoking is still not in place in all states in America, but when they did those bans, it actually led to significant improvements for drinking. And we haven't even begun to talk about the vaping bans that could be in place, but I think this is a space that we need to be in. So I'm over time, but I want to acknowledge my collaborators and there. Oh, sorry. I'm going to stay here. Do you want to sit anywhere at that table?
That was great. Thank you so much. And hopefully that prompted some questions among you all, but we're going to save those and have a question and answer session at the end. So thank you. Our next presenter is me. And I'm going to move us, follow Lisa's nice presentation on smoking among folks with alcohol use, and move us to individuals who smoke and also have opiate use disorder. And just a quick acknowledgement of current and prior funding for some of this work, as well as no disclosures to share. As was already covered very nicely in the past talk, we're all aware that combustible cigarette smoking is still a significant cause of disease, disability, and death, although it has markedly declined over recent years to the point of about 11% of U.S. adults smoking. However, as we all know, it's deeply entrenched in vulnerable population subgroups of individuals, and in particular, those with substance use disorders. Prevalence of smoking is about fivefold that of the general population. And if we take it one step further and focus on people with opiate use disorder, or OUD, the prevalence of smoking is higher still. So about 73% of folks with OUD report past month smoking. And then if you look at the subset of those who are currently enrolled in agonist medication treatment for OUD, buprenorphine or methadone, it's about 90% of those patients report current smoking. And when we look at this group, they are more likely also to become nicotine dependent. They're more likely to have a higher severity of nicotine dependence, as well as to may experience greater severity of nicotine withdrawal. Furthermore, the mortality rate for individuals with OUD who smoke is about 4 times that of folks with OUD who don't currently smoke, with about 1 in 2 who seek treatment for OUD dying from tobacco-related deaths. When we look at their response to standard kind of first-line interventions for smoking cessation, we see that they're notoriously poor. So among folks with OUD who smoke, quit rates tend to be about 1/4 that of those without OUD or other SUDs. As you can see depicted here. And when we think more about the first-line pharmacotherapies that have shown to be effective in the general population for smoking cessation treatments, the responses among individuals with OUD tend to either be non-existent or very modest. And so, compared to maybe a 20 to 33% typical outcomes associated with first-line pharmacotherapies in the U.S. general adult population, we see about 0 to 13% response rates in folks with OUD who smoke. And so this has really prompted clinicians and researchers to kind of start to conclude that maybe it may be impossible to touch smoking in this population, but if we are going to have a shot at having some favorable outcomes for smoking cessation among individuals with OUD, it'll likely require either more intensive interventions than those that had been, examined thus far, and then potentially also some innovative regulatory or policy-related changes. And these 2 areas are have been areas of focus of some of our studies here in the past 15 years or so here at UVM. In the category of more intensive interventions, we've been focusing, and I'll share data on some behavioral economic interventions. And then in the realm of policy changes, I'll be sharing some of our data on reduced nicotine cigarettes in this population. So kind of preaching to the choir probably, but contingency management being, a highly effective behavioral approach that reduces, has been shown widely to reduce drug use of all types and promote other health behaviors by providing non-drug reinforcers contingent on the target behavior, in this case, abstinence. Typically, financial incentives provided contingent upon submitting biochemical, like objective evidence of drug abstinence. If it's smoking abstinence, it would be expired breath CO or urinary cotinine. And some of the initial studies conducted in this area, not by us, but by folks you see here, really were exciting in that they began to show some of the first demonstrations that smoking among patients with OUD may actually be sensitive to an intervention. They demonstrated better short-term abstinence outcomes than what I described in the previous slide with pharmacotherapies and other light touch approaches, showing that they could get about 25 to 35% of smokers with OUD to respond. However, many of those folks still persisted in their smoking in the first 2 weeks of the intervention, and that has been widely demonstrated as a robust predictor of poor longer-term outcomes, any smoking in that first 2 weeks post-quit attempt. And so we were interested in trying to dig into this a little more and try and first conduct some studies to really look at how we might go about maximizing or improving that initial response to a smoking intervention in this kind of hard to touch group. And so with a behavioral intervention, a contingency management intervention, we decided to focus on some parameters that we know are effective that can really impact efficacy of an intervention. So we designed some studies and intervention that included more frequent visits, more frequent biochemical monitoring, more rigorous approaches to it, which I'll describe in a minute, and larger incentive magnitudes to really essentially see what would it take to get these folks to quit smoking. And we conducted 2 studies, and I'll just briefly touch on them. In both, participants, to be eligible, they had to be maintained on buprenorphine or methadone and have smoked 10 cigs per day or more for the past year. And the first 2 studies were just really get in, get out, just 2 brief 2-week studies. It was intensive. Participants had to come to the research clinic every day for 2 weeks, provide both a breath and a urine sample for CO and cotinine testing at each visit. And they were randomized to either an intervention group, contingent voucher-based incentives for biochemically verified abstinence, or a non-contingent yoked group. And in these studies, we did this transition approach where we used breath CO as the criterion for abstinence in the first few days. That way, we didn't have to wait for several days to pass before we could reinforce abstinence like you would have to do with the urinary cotinine level. But then we did want to do all we could to try and minimize the ongoing undetected smoking in the initial days, again, in this 2-week period that's so critical for longer-term success. And so on day 6, we switched to an abstinence criterion of urine cotinine level of 80 nanograms per mil or lower. And then, as I mentioned, we also increased the magnitude of the incentives, which is an important parameter or determinant of efficacy. And so here you can see we utilized an escalating schedule, where the longer that they were smoking abstinent, the more they could earn, some strategically placed bonuses to help folks achieve that early abstinence, and by making that transition to urinary CO on day 5 or 6, complete abstinence ideally. So to do all we could do to promote that initial response. And in both studies, the first studies presented in the top panel, the second study in the lower. In both studies, participants randomized to the contingent intervention achieved significantly greater amounts of abstinence, actually right on top of each other, 55% in both studies compared to 5 to 15% of abstinent samples in the control group. They also achieved longer durations, not shown here, but significantly longer durations of abstinence than the control group. And so if you think about these, rates of abstinence, they were favorable if you compare it to some of the prior studies in terms of looking at initial response to pharmacotherapies and even some of the earlier behavioral interventions with this population. But still only 2 weeks. So really very brief, get in, get out. And so our third study was, we sought to focus more on what would it take to maintain that abstinence that was achieved in the first 2 weeks. And so in this third study, if you think about that contingent intervention that half of participants got randomized to in the preceding 2 studies, everyone in this trial received the first 2 weeks of just that efficacious contingent incentive intervention, the same intensive daily visits for biochemical monitoring, the same transition from CO to urinary cotinine on day 6 for the abstinence criterion. And then on day 14 is whenever we randomized them to phase 2. So we wanted to see if essentially, is it necessary to maintain the intervention in order to sustain the abstinence that was produced in that first 2 weeks, or did we cure them? Is it set and, we can just step back and that's all it takes is just really doing all you can to maximize abstinence in that critical first 2-week period post-quit attempt. And so in this study on day 14, participants were randomized either to continue that extended contingent, 10 more weeks of voucher-based incentives contingent on this time all the urinary cotinine abstinence criterion, or 10 weeks of a yoked non-contingent incentive condition, control condition. As I said, abstinence continued to be defined by cotinine, and we did gradually decrease the frequency of visits over time, as you see here, and that was the same for the 2 experimental groups. So what we saw first, again, in phase 1, when both groups received the same contingent intervention, we saw high rates of biochemically verified abstinence, with about 75% of samples smoking negative in that period, as you see here. And then on day 14, at the end of that 2-week period, 62% of participants submitted a urine cotinine sample that met the abstinence criterion. And then when we looked at phase 2, following the randomization to the 2 experimental conditions, significantly greater abstinence, as you might expect, from the extended contingent folks, with 47% of urines versus 24 being negative for smoking during that period. And you can see that separation there. So, some of these early studies, we thought suggested that with a sufficiently intensive intervention, we might be able to produce smoking abstinence among a meaningful subset of individuals with OUD, at least for several months, at least for still kind of a short period. And if you think about it, I think it's important for us to think about this because so many of these folks are receiving MOUD treatment across the country. And there are a lot of features of opiate treatment programs that really could lend towards the widespread dissemination of an effective intervention. Patients often are clinically stable for months or years. They often come in fairly regularly. They're often, engaging in other forms of clinical contact counseling and stuff. And so it could be a really prime kind of setting in which if you identified and developed an effective intervention, you could have actually a shot at disseminating it pretty broadly. However, certainly more work remained and remains to be done. What we are likely to head into is examining some longer durations of interventions beyond the 12-week phase, and again, see, what that abstinence looks like over longer periods that are, as Lisa was saying, probably important and more reality-based, in terms of needing longer-term interventions. And then also, tackling some of the challenges associated with CM intervention adoption, such as identifying sustainable funding or reimbursement, implementation, kind of practical logistical details, quality control, et cetera. Another area that more recently, since we completed those studies that I just described, we've been digging into is, again, looking at yet other approaches for reducing smoking and related harms in this population of individuals with OUD who smoke. And that moves us to the second kind of area of interest that we've been focused on. And that is reducing the nicotine content in cigarettes to very low levels. And I'm sure we'll be hearing a lot more about this in the next 2 days. But as most of you know, the idea is that this may really render cigarettes less addictive. It's so far in the general population, the studies have shown that reduced nic cigs can decrease smoking rate and dependence severity without what was the concern of a big burst in compensatory smoking, in the general population. This is all very exciting. The FDA, is seriously considering policy changes along these lines. One of our questions at UVM in recent years has been, might low nic cigs hold potential for reducing smoking and smoking related adverse consequences among those high risk subgroups of smokers, and in particular among what I'll share are smokers with OUD. And so what I thought I'd do here is we've been looking at, in a completed study that you all have probably seen, maybe what can we glean from some additional takeaways related to specifically the smokers with OUD and how they responded differently or similarly to our larger group in response to reduced nic cigs. And so this was a study again here at UVM, 3 parallel RCTs, a total of 775 daily adult smokers. And we had 3 high-risk smoker populations, those with affective disorders, women with high school education or less, so socioeconomic disadvantage, and then adults with opiate use disorder. Across all 3 populations and 3 trials, participants were randomized to receive 12 weeks of double-blind exposure to one of 3, that should be of, cigarette conditions. So first was study cigarettes with nicotine levels that essentially were reflective of commercial levels, 15.8 milligrams nicotine per gram tobacco, or one of 2 reduced nicotine levels, 2.4 milligrams nicotine, or 15% of control levels, or 0.4 milligrams nicotine, which is 2.5% of control levels. And some of the outcomes that we examined included cigarettes per day, nicotine dependence severity, and then biochemical measures of smoking exposure. And you see the specific outcomes there. So what we saw in the primary and study in terms of cigs per day, the primary outcome is, so first I'll kind of share, how did these 3 vulnerable study populations, when combined, respond to the manipulation and nicotine dose. And so as you see here, the VLNC doses were associated with reductions in smoking. And that was evident both if you look at the total cigarettes per day smoked as well as study cigarettes. And when we looked at just in secondary analyses more recently of just the smokers with OUD, we saw that similar to the other 2 vulnerable study populations, VLNC doses were associated with reductions in smoking among our participants with OUD. It was interesting, however, that those folks with OUD who were randomized to the lowest VLNC dose, the 0.4 milligram cigarette dose, did show some poor study cigarette adherence, so somewhat higher non-study cigarette use than the other folks. And that was especially kind of evident in the first few weeks of the intervention. And so that was kind of an interesting potential way in which these guys may be a bit hard, more challenging in terms of their adherence than the others. When we also looked at the outcome of nicotine dependence, again, first, when we look at combine across the 3 vulnerable smoker study populations, we saw, and as you see here, that the VLNC cigs were associated with reductions in nicotine dependence. And however, when we looked specifically at the smokers with OUD, we saw not so much. The VLNC doses were not associated with reductions in nicotine dependence, which may not be surprising if given what I just said in the previous slide about some adherence challenges. So this was a way in which they may differ a bit from the other 2 populations that we've been working with. Lastly, biochemical measures of smoking. And so that was, kind of a consistent picture that combined across the study populations. The VLNCs were associated with significant reductions in breath CO, as you see in the figure, but also cotinine and NNAL. When we looked at just the subgroup of smokers with opiate use disorder, they were not generally associated with reductions in biochemical measures. And so again, kind of a way in which they differed from the other guys and likely a function of the adherence that we were just touching on. So, if we step back and just think more about this population of smokers with opiate use disorder, what will it take, to help promote abstinence? If we think about it through the lens of more intensive interventions, I think it's exciting that we've identified and been investigating and showing some behavioral interventions like CM that can actually produce pretty robust responses, often higher levels of abstinence than have ever been seen in this population and often than are seen in general. I think the key will be how can we sustain those effects and what level of intensity would be needed to sustain them over time. So certainly more, future research and implementation science efforts, I think will be important to really dig more into the duration and persistence of the effects. I always, tend to think also, what about those folks with OUD who are not enrolled in buprenorphine or methadone treatment, right? So they're going to be even less stable. Like we kind of didn't handpick our participants for these studies, but we wanted them to be enrolled in treatment. And, because we thought you probably don't have much of a shot of tackling someone's cigarette smoking if they're not in treatment and they're actively using heroin or whatever. And so, you got to pick your battles. But it's an empirical question. And there are plenty of those people out there and that would benefit from more effective smoking cessation interventions as well. And then, as I mentioned, also just really exploring and digging into more ways to support the adoption and implementation of these approaches in clinical settings. And then, in terms of the potential reduced nicotine cigarettes, I think it's, it's clear that decreasing nicotine content of cigs to very low levels can reduce smoking among all kinds of vulnerable populations that we've looked at and others. However, it seems to me that we need to be thinking some more about how to strategically support or promote their adherence and whenever we're seeking to get these patients to use reduced nic cigs. Overall, as we're all aware, and as the theme of this conference, our time together, vulnerable populations like those with co-occurring SUDs and mental health conditions, they do make up the majority of folks who smoke. They do experience disproportionately greater smoking-related adverse effects, morbidity, mortality. And there's an urgent need to develop more effective interventions, as doing so not only stands to reduce smoking-related harm in this clinical population that we've been working with, but of course tobacco-related disparities more broadly. And I'd like to thank our co-authors and collaborators, and thank you. So maybe I'll pivot to introducing, maybe Chris, can you set this up? Our third and final presenter for this session, Joanna Streck. So Dr. Streck, previously a UVM student with us, also a licensed clinical psychologist, and now an assistant professor in Harvard Medical School's departments of psychiatry and medicine, will be our final presenter from in this session. Joanna is also the associate director of addiction science research and programs and a core faculty member of the Tobacco Research and Treatment Center at MGH. Her program of research seeks to identify effective tobacco cessation and harm reduction interventions for vulnerable populations who smoke, including those with comorbid SUDs. And the title of Joanna's talk is Developing and Testing Novel Tobacco Treatments for Adults with Opioid Use Disorder.
Thank you. See if my height can fit behind here. Yes, so I am going to share with you all our efforts in developing and testing different tobacco treatments for adults with opioid use disorder. We know that medication treatment for opioid use disorder dramatically reduces opioid-related morbidity and mortality. However, tobacco use disorder remains a leading cause of preventable death in this population. As we heard from Stacey, we see that this group really has high prevalence rates of smoking and limited success in quitting smoking. Now, why do we see such high rates of smoking and limited quit success among adults with opioid use disorder? There have been several hypothesized mechanisms for maintaining smoking in this population based on data in the empirical literature. The first is neurobiological interactions between nicotine and opioids. So we see dose-dependent increases in nicotine self-administration upon administration of opioids. We see that this group has higher levels of nicotine dependence and a heightened sensitivity to nicotine withdrawal. And a set of factors that I've been particularly interested in recently are these important social factors likely to maintain cigarette smoking in this population. So these are things like the pro-smoking social norms and opioid treatment, the high social acceptability of smoking, the limited social networks comprised of other peers and family members, and then an overall limited social support for quitting smoking. There are also important social factors in one's environment that negatively impact their cessation success, called social determinants of health. So factors such as inadequate access to transportation, housing, financial insecurity. And you can see how if you have trouble with transportation, that would make it hard to go pick up a medication refill for your tobacco use disorder. And these social factors really have not been adequately addressed in prior smoking cessation interventions for adults with opioid use disorder. And all of the factors that I listed here likely contribute to yet another factor, which is that this group really struggles to adhere to different tobacco treatments. And the last piece that I'll mention is just that this is a group that really has inadequate access to evidence-based tobacco treatment. So across primary care, behavioral health, and even addiction treatment settings, we see a really limited provision of evidence-based tobacco treatment, likely in part due to continued staff and provider perceptions that tobacco use is less of a urgent treatment priority. So what novel strategies can help surmount these barriers to tobacco abstinence in adults with opioid and tobacco use disorder? There are two promising newer approaches. The first is one I think this audience is quite familiar with, electronic cigarette devices. These are particularly unique potential smoking cessation tools because in addition to providing nicotine replacement, they provide those important sensory motor stimuli that mimic smoking. So those conditioned stimuli like the hand-to-mouth behavior, the fact that there's exhalation of vapor. And for adults with opioid use disorder, this could be a particularly useful tool given we know that they often smoke in social situations. So could they replace that with a vape device? And then the nicotine replacement in the e-cigarette could help with the symptoms of dependence and withdrawal. And in the general adult population who smokes, we see high acceptability and efficacy of e-cigarettes for promoting cigarette cessation. So complete substitution of e-cigarettes for cigarettes has the potential to reduce cigarette-related harms, although in people with opioid use disorder, dual use remains a concern, so the continued use of cigarettes with the introduction of e-cigarettes. But overall, much more research is needed to thoroughly test electronic cigarettes as potential cigarette cessation tools, specifically in this population. A second separate promising approach is peer recovery coaches. So these are individuals who have lived experience with addiction themselves, and they provide a non-clinical support coaching. So in the case of people with opioid use disorder, they're coaching patients in opioid recovery. And they're really emerging on the scene as part of a new standard of care for treating addiction. They're employed by many healthcare institutions in many states, and they're really considered now part of multidisciplinary addiction treatment teams. And the data that's emerging on the effects of peer recovery coaches for addiction treatment are really promising. We see that peer recovery coach contact is associated with increased patient treatment retention and addiction treatment, illicit opioid abstinence, and importantly, patients are reporting that they find peer coaches helpful for promoting general addiction behavior change. They view them as credible sources of information, and they decrease stigma around medication treatment for opioid use disorder, which is important in light of the perpetuation of abstinence-only models. Now, importantly, payers, including Medicare and Medicaid, are beginning to cover peer recovery coach services for addiction in a fee-for-service reimbursement model, so they could be particularly sustainable interventionists. So I've hypothesized that peer recovery coaches in both opioid and tobacco recovery, so those who are also former smokers, would be particularly useful interventionists to increase the delivery and uptake of tobacco treatment among people with opioid use disorder, and also to address those social factors and social barriers to quitting that I listed in the prior slide. But this has never been tested, nor is there data looking at peer recovery coaches' own tobacco use status, nor their views about integrating tobacco treatment into the peer recovery coaching role. So that brings me to my two specific research questions. The first is, can electronic cigarettes help adults in opioid treatment who smoke quit or reduce their combusted tobacco use? And then a second separate question is whether a tobacco cessation intervention delivered by tobacco-trained peer recovery coaches who are in both opioid and tobacco recovery increase tobacco abstinence in this population. So today I'm going to share data with you all from 3 different studies to address these research questions. The first 2 studies were 2 survey studies, part of a K-12 funded postdoctoral fellowship that I completed a few years ago. And the first survey study that we did looked at the perceptions of e-cigarettes by adults in treatment for their opioid use disorder. And then we did a second separate survey study looking at tobacco use and opinions about tobacco treatment by our addiction peer recovery coaches. And these data served as pilot data for a trial that was recently funded, which is a clinical trial testing the feasibility, acceptability, and preliminary efficacy of providing NIDA standardized research e-cigarette to adults with opioid use disorder to test cigarette cessation and reduction. So I'll start by taking you through the 2 e-cigarette studies. As I mentioned, the first study is a cross-sectional survey. So here we're surveying adults receiving primary care-based buprenorphine treatment for their opioid use disorder in 2020. We recruited across the 5 community health center practices in our Mass General Hospital healthcare system. We did so by downloading a list of patients receiving buprenorphine treatment from the electronic health record system. We got their providers permission to outreach to the patient, and then we offered them participation in a survey and an additional interview. And today, just for the sake of time, I'll just present our survey data. So we had 222 survey completers who were on average 46 years old and had been in opioid treatment for 3 years. So they were stable in their opioid treatment. 72% reported past 30-day cigarette smoking, 31% reported past 30-day e-cigarette use, and 22% reported dual use of both cigarettes and e-cigarettes. We asked participants how harmful to their health they thought 3 different tobacco products would be: cigarettes, nicotine, e-cigarettes, and NRT. And you can see in the legend that response options were rated on a Likert scale, ranging from not at all harmful to my health to very or extremely harmful to my health. And here I'm presenting our data across current use of the product. So if we start with cigarettes, we see across participants in opioid treatment using and not using cigarettes in the past 30 days, the majority of participants are correctly rating cigarettes as very to extremely harmful to health, denoted by that black shading there. For nicotine e-cigarettes, responses were a bit more divided. The majority did rate e-cigarettes as very to extremely harmful to health, though we also saw a subset of folks in the gray and white bars rating e-cigarettes as somewhat harmful to health and even not at all to very harmful. And then finally, for nicotine replacement therapy, across those using and not using NRT, the majority of our participants are correctly perceiving or rating NRT as not at all to slightly harmful to health. Though interestingly, you do see some misconceptions, particularly among those not using NRT, where we even see there's that 12% in the black that's rating NRT as very to extremely harmful to their health. We also asked participants about the comparative harm of cigarettes and e-cigarettes, and most of our participants, 58%, rated cigarettes as more harmful than e-cigarettes. We went on to ask participants how helpful they thought e-cigarettes would be for quitting or cutting down on cigarettes. And here, again, we're looking at responses across current use of e-cigarettes. And we see that most of our participants believe that nicotine e-cigarettes would be very or somewhat helpful for quitting or cutting down on combusted cigarettes. And most of our participants said they'd be interested in participating in a future trial where we asked them to switch from cigarettes to e-cigarettes. So in conclusion, while some of our participants did express concerns about the absolute health risks of e-cigarettes, it seemed like despite that risk, they thought they could also be useful cessation tools, suggesting a potential alignment with a harm reduction view of e-cigarettes. So we concluded that e-cigarettes are likely an acceptable tool to adults in opioid treatment for promoting tobacco cessation. So the next e-cigarette study is an RCT testing switching 40 adults with opioid and tobacco use disorder who are not yet ready to quit smoking from cigarettes to e-cigarettes. So presented here is our study schema. We have a pre-screening for eligibility. Then we have a baseline 1-week monitoring period where we monitor their usual brand smoking habits. And then at the end of the baseline 2 visit, we randomly assign participants to either immediately receive e-cigarettes for 8 weeks, which is our SREC provision group, or to receive them after an 8-week delay, which is our waitlist control group. In both groups, we follow up with participants 1 month after e-cigarette provision ends. And across all of our assessments, we collect urinary and breath biomarkers of tobacco exposure. We also have a daily texting paradigm. So across the 1-week monitoring period at baseline, we send out daily text asking about the number of cigarettes smoked on the prior day. And then we send out daily text during the e-cigarette provision period asking about the prior day's use of cigarettes, study and non-study e-cigarettes, and any other tobacco products or cessation aids. And we also send them to the waitlist control participants during their waitlist period just for comparison. So for this study, we began recruitment recently this past June. When I made these slides a few weeks ago, we had randomized 8 participants. We ended up having to exclude 1 after randomization because he didn't like the taste of e-cigarettes and didn't feel he could continue on in our study. So today I'm going to present data from the first 7 randomized participants. And on average, these first 7 were mostly male and had been in opioid treatment for about 2 years. So presented here are cigarettes per day data from the daily text. So on the y-axis, we have the mean cigarettes smoked per day. On the x-axis, we have each studied day. That dash line denotes when the intervention starts. So to the right of the dash line is our 8-week intervention. The blue line is the SREC group who's getting the e-cigarettes provided to them. The red line is the waitlist control. And we see this reduction in cigarettes smoked per day reported from baseline in our SREC group. And in contrast, we see relatively stable levels of smoking in our waitlist control group. Here, we're also looking at mean cigarette smoke per day on the y-axis, but now we're looking at individual participant data. So each dot is an individual participant and their data on a specific day. And here, a blue dot means that they reported using an e-cigarette, and a red dot means they did not use an e-cigarette. And we can see on the left-hand panel graph, which is our intervention group, the SREC group, that of those who are reporting reducing their cigarettes smoked per day, most of those participants are also reporting using their e-cigarette. So evidence of potential successful switching to e-cigarettes. In contrast, in our waitlist control group, we mostly see red dots. They're not using e-cigarettes, which makes sense since we're not providing them. Though interestingly, we do see 1 participant who went out and bought a commercially available e-cigarette during the waitlist period. So very preliminary conclusions are that the data from the first 7 participants look promising. It looks like providing e-cigarettes may help participants in opioid treatment reduce their cigarette smoking. Our goal with this study is to complete our recruitment by this coming June of 2025. Turning our attention to the last study that I'll talk to you about today, this is our peer recovery coach tobacco study. This was our second cross-sectional mixed method survey. Here we're surveying our peer recovery coaches employed by our healthcare system, and we completed this survey in 2022. Some context that I'll share with you for the data that I'm going to show is that for most peer recovery coaches, including those employed by Mass General, our coaches are asked to complete a certification training program upon being hired. So we ask our coaches to complete the DPH-sponsored certified peer recovery coach training. And this includes different skills relevant to coaching on addiction, like motivational interviewing, and then also how to make community linkages that address those social factors that I listed on the prior slide. Peer coaches right now are not formally trained to deliver tobacco treatment. So for this study, we recruited in our 12 addiction treatment programs at Mass General, where we employ 1 to 3 coaches per clinic. For this survey, we outreached to all 26 coaches employed by our healthcare system, and we had a pretty good response rate. 23 responded to our survey, and then we had 20 complete an additional qualitative interview. And I will present data from both of those today. Our 23 completers, our coaches were on average 51 years old. They had been working as a peer recovery coach for about 7 years. Most were in recovery from polysubstance use. The most frequent combinations were between opioids and alcohol and opioids and stimulants. In terms of the coach's own smoking status, 32% of our coaches reported current tobacco smoking, 50% reported former smoking, and 18% had never smoked cigarettes. In order to get a baseline understanding of our coaches' current tobacco-related practices, we asked them how frequently they engaged in certain pro-smoking cessation practices. So the black represents engaging frequently, sometimes, usually, or always, which I collapsed for presentation today. And the white bars represent engaging in a practice never or rarely. And we see that our coaches are often reporting that they ask their patients, also called recoveries, whether they smoke cigarettes. They talk to them about quitting smoking. They advise them to quit smoking, and some are even sometimes recommending e-cigarettes to reduce cigarette-related harms. Now, in contrast, we also found that our coaches were engaging in different pro-smoking practices. So we had coaches reporting that they smoke cigarettes with their recoveries. They bring them outside from treatment to smoke cigarettes. They provide them with cigarettes sometimes, and they reported using cigarette smoking to build the peer relationship. Despite this, most of our coaches who reported former smoking thought that they should have a role in helping their recoveries quit tobacco smoking, and they said they were interested in getting tobacco treatment training to do so. Our qualitative data were really useful for understanding more about the pro-smoking practices. So across all of our peer recovery coaches, a consistent theme that came up in our qualitative data was that they were engaging in these pro-smoking practices because they believed they were reducing patients' harms in other domains. So this is a representative quote from one of our current smoking coaches who said, "A lot of times people left the hospital against medical advice because they couldn't smoke. We started taking them out once a day to smoke and they'll stay. Ever since we started doing that, people have been staying a lot more." And this came up a lot around patients who are hospitalized on our medical units for infectious complications related to their addiction, who would have to be inpatient for about 6 weeks to complete the course of antibiotics. And the coaches frequently reported that patients would leave, they didn't want to stay, and so they would take them outside. Another representative quote, this from a former smoking coach: "People are taking used cigarette butts out of the ashtray. That's disgusting. We're in a pandemic. I'd rather give you a clean cigarette because that's harm reduction. I'm reducing harm by giving you a fresh cigarette versus anything else that's going to happen in that smoke shack." Another representative theme that came up was among our former smoking peer recovery coaches who thought that they could use their lived experience quitting tobacco to help others quit. And many of them also named specific skills that they could use. So this is another representative quote where this coach says, "I'd also provide my personal experience, the way that I quit cigarettes, to be able to identify with them, how hard it was, being compassionate, understanding that it's not easy, and then also making a game plan for at least reducing the amount that they smoke." In contrast, our current smoking peer coaches made it really clear that they did not think that they should have a role in helping patients quit, and that they felt that that would be hypocritical given they themselves were still smoking. So some conclusions from this study is that our peer recovery coaches' attitudes about integrating tobacco treatment into addiction recovery coaching were generally positive. These positive viewpoints were mostly held by our former smoking coaches. Peer recovery coaches could benefit from tobacco treatment training to potentially replace those pro-smoking practices with evidence-based treatment skills. So could they go and take a patient off the floor, give them nicotine replacement to help with the craving and withdrawal, and go on a walk without providing a cigarette? So we concluded that peer recovery coaches in both opioid and tobacco recovery with tobacco treatment training may be feasible and innovative interventionists for those with addiction. Our future directions with this line of work, we have several projects under review testing a peer recovery coach delivered tobacco treatment for adults with co-occurring substance use disorders. The overall goal with the 2 lines of research that I shared with you today are to develop research and data and be able to build a tobacco treatment toolkit for patients who smoke, who have co-occurring addiction, and include things in the toolkit across the harm spectrum so patients can choose from different options and find things that work for them. The last thing I'll say today is that although this is a population that has lower rates of abstinence compared to those without these conditions, this is a group that is able to quit smoking, but we really need innovative interventions, including innovative ways of delivering these interventions and also funding and sustaining them. And finally, we really need interventions which address the unique barriers that this population faces, namely those social factors. I'll end by acknowledging the wonderful mentors that I've worked with, highlight our keynote speaker, Nancy Rigotti, who is an integral part of all of these projects, thank the study team, and then also our participants and coaches who really helped guide us and understand what was going on. Thank you so much for having me. I will end there.
Thanks, Joanna. Well, we have time for questions. I think our protocol, right, Chris, is for anyone with a question to go to a microphone and then. But maybe I'll get us started because Joanna, I was thinking of something
Yeah.
while you were. So it was really funny to see the different response among the peer recovery coaches who were former smokers versus smokers. And it kind of illustrated to me the power, like, would you think of actually an intervention, a smoking cessation intervention specifically for peer recovery coaches so that they could be like really powerful,
Yes.
train the trainer, and they've already successfully quit illicit opiate use and other substances. And so they'd be, is anyone doing like directly targeting the peer recovery?
Not that I'm aware of. We
Smoking?
have discussed this. Nancy runs an employee cessation program, and we have discussed how to help them quit. I think that's a great idea. I also wanted to acknowledge that Dr. CEO from Brown, I saw you recently published something on HIV navigators, so feel free to chime in on the peer discussion if you have any experience, but no, I'm
So
not
like
aware.
amplify the effect. It
Totally.
just seems like it
Yep,
would-
or a phase
plus-
1 of a study to first help them quit,
Yeah,
and then
and
they
then-
use their more recent lived experience. Yeah, it's a
Yeah,
great
that'd be
idea.
cool. All right, Eli, do you have a question?
Yeah, thanks for a great series of talks. I have a question for Dr. Fucito. The data you presented on the correlation between prevalence of smoking and alcohol use is really interesting. And I'm wondering if you know of, have thoughts on whether that is specific or how specific that is to combusted tobacco. And really what I'm wondering is among people who have switched from cigarettes to e-cigarettes, would you think that using alcohol could increase relapse to combusted cigarettes, or would e-cigarettes already fill that kind of craving for nicotine that comes up with alcohol use? Any thoughts you have on that, or research that's addressed that?
Yeah. Is this on or?
It is.
Okay.
Yeah.
Yeah, I think that's a great question. I think because we just generally see, like Joanna mentioned, that this is a population that can experience worse withdrawal. And I think there's, overlapping pharmacological mechanisms. I think we may likely see some of those associations that we see with combustible tobacco transitioning with some of the newer non-combustible tobacco products. I think it also has a lot to do with the environment that people find themselves in. And the reason that people are using e-cigarettes relative to using combustible cigarettes. So I think if you have a strong sort of social component where you tend to, it's interesting. Apparently I had 3 more minutes and thought I only had 20 minutes. So I can do a part 2 like at lunch or something. Since I just like breezed through all that. But what was interesting in the integrated treatment study that I apparently couldn't talk to you about, this sort of social aspect of smoking and alcohol use is very strong for men. Like they tend, we would say, like we had some participants in the study who were like, yeah, after we're at the car shop, we pull out the lawn chairs, we get the beers, and we're all around sort of smoking and using smokeless tobacco. Women were on the internet alone by themselves, smoking and drinking. And so I think there's sort of different reasons why people might be using, and I think for men in particular, there was a very strong social component. So I think if you end up kind of transitioning to using e-cigarettes and it's still very social and you're out in drinking context, I think you might be at risk. But if your association to it is different, and you just really need that nicotine dependence, perhaps you could be okay with just transitioning to e-cigarettes and not relapse back to smoking. But I think we're only just beginning to understand people transitioning to e-cigarettes and then what are the contexts in which they use. But some people say that they really don't see them being related. And then for some people, they feel like the two go together very strongly. So I think some of it you almost have to ask people, how do you tend to use these? Do you use them together? Are they separate? What do you think is the impact of using one on the other? And if you were to try to avoid using one, what would that? So I think there's different phenotypes that might play a role that would be important for that.
It's
Yeah.
funny, that's the functional analysis type of
Mhm.
conversation we would do in the cocaine clinic years ago. So it's just funny that
Yeah.
that holds a lot of potential for e-cig and understanding e-cig and combustible and their intersection too.
Yeah.
Yeah. Next question.
Thank you for some wonderful talks. I have 3 questions from the online portion of our viewership. The first one is for Stacey. So in your lower nicotine study, did participants have the opportunity to switch to higher nicotine vape and pouch products?
Not in the study that I shared. No.
The second one is for Joanna. There's growing evidence of the harms of e-cigarettes, and they may be more harmful than we thought. Are you comfortable with using them as a harm reduction tool with this growing knowledge?
So one thing to clarify is that the studies that I showed is among adults who smoke cigarettes. So I didn't present this today, but we have certain inclusion criteria. They have to currently smoke heavily. So yeah, what I'm testing is among adults who smoke versus introducing it to someone new. And that's part of what we're testing is whether exactly our empirical question is whether we see a reduction in cigarette smoke per day in this group. And yeah, Nancy, if you want to chime in on any of your things you've published on that, feel free to, but yeah, that's the relevant information about my study.
And then the third question comes from Rhonda Williams, who asks, I'm interested in the speaker's thoughts on testing implementation of CM and peer recovery together with tobacco treatment trained recovery coaches.
Yes, I was actually just saying this to Stacey. I had a slide on that and then I took it out because it felt like I was getting too all over the place, and I was taught to be very focused in my efforts. But yes, that is something that we've been mulling over, especially because if we can bill peer services, it's a way to kind of sustain this model. So yeah, I think a peer recovery coach delivered CM intervention compared to a CM intervention delivered not by a peer recovery coach is a fantastic thing to test for general addiction or for tobacco use. Yeah.
Thank you.
Thank you.
Hi, Trish Seal from Brown. So really interesting presentations. Thank you so much. As you mentioned, I'm very interested in peer supported interventions. And actually, that's what I'm going to present on today, that recently published study. So really exciting to see that extend into patients who also are being treated for either opioid use disorder or, I've had thoughts about doing that within the alcohol realm too, because, the 12-step programs have had sponsors, as they call them. So I just think it's a huge untapped resource within our clinical care so that we could cross-train those types of allied providers or support services in tobacco cessation as well. So thank you.
Yeah, thank you.
Hello, my name is Grace Call from Yale. Thank you so much for this symposium. I think you guys really highlighted the importance of addressing tobacco cessation among people who have alcohol use disorder as well as opioid disorder. I was thinking a little more about dissemination, and I know you guys sort of all touched upon this, but so people, Lisa mentioned there's no integrated treatment. There needs to be more of that. So when people come in for alcohol use or opioid, when is a good time to introduce tobacco cessation, right? When they're dealing with other things, have you found a good way to think about the best time to introduce these nice interventions that you're all sort of testing?
It's a great question. I know we had this clinical stability criterion but we did not experimentally manipulate, how long they've been in treatment and when to start.
Yeah, and I think most of what we our two studies were among people already stable in treatment. But one thing that I'll highlight there, Kimber Richter, she recently presented on the opt-out approach and this idea that we should really be offering everyone tobacco treatment at all times. And there's some have critiqued that or said that that's not patient-centered, and she gives a really beautiful presentation explaining how it actually is really patient-centered to offer everyone treatment. Like you wouldn't say to someone who has heart disease, you wouldn't say like, oh, do you want to get help with your heart disease? You would just say, this is an evidence-based tobacco treatment. So I think there is a movement towards just offering it to everyone. And then if they say no, they say no. But yeah, I think Stacey was highlighting that in her talk, that question about how we should address those not in opioid or addiction treatment. And I do think that objectively would be a challenging group to try to engage when they have so many other factors that are more immediate than.
But no need for them to be in MOUD for 3 years before you try to
Yes.
quit,
Unless you wanna be in our
but we need to
studies,
look
yeah.
more at that, like what happens if you try them concurrently or just slightly sequentially, and I think that's an important question.
Yeah, and I would just add that I think it's still surprising that in inpatient settings, it's not offered.
Yeah.
Like the extent to which people are leaving against advice because maybe they're not being given medication. So I think in an inpatient setting, if somebody's there for their other substance use, I think it should just be a routine question that's being asked because they're going to have a strong need for withdrawal management. I think the outpatient question, there's so many reasons that probably go into why it's not addressed. To this day, Ann Joseph is the only study that I know that was conducted that suggested you couldn't provide it concurrently. And it potentially was better to do it sequentially, but she's the only study to date, especially with alcohol use disorder, that showed that effect. So I just think because it's likely that they're not going to get it elsewhere, that it should just be offered. And then if somebody is sort of struggling, I think you can sort of dial stuff back. But even just to tell somebody, just work on seeing if you can cut back. I mean, just reducing your drinking usually can help people cut back on their smoking. So yeah, it's such an important question that we still haven't really navigated.
Hi, thank you all for your presentations. And actually, this is my exact question. So I kind of wanted to build off of it a little bit. It was going to be directed towards Dr. Streck, but anyone can maybe answer. But I was actually wondering if you have any information about what percentage of individuals are being offered treatment for smoking cessation when they come through the emergency department, and within those people, what proportion might be accepting it. And then I was wondering what you thought about what your thoughts might be for conducting a study that might examine offering use of, like, for example, nicotine replacement therapy on retaining people in the emergency department, and preventing them from leaving against medical advice.
Yeah, that's a great question. I think I don't know if this is something that you've tried to work on, but so we have an addiction consult team who consults in the emergency room and provides general addiction treatment. And then there's the transition to people who get hospitalized and stay. I think in our healthcare system, it has been challenging to you can speak more to it, but to have tobacco treatment be part of that flow. But I think I think what you're raising is an excellent idea. It's like the earliest stage that we could intervene of someone who ends up being hospitalized. But I know at least in our healthcare system, it's been a challenge. Yeah.
Studies that have been done offering treatment in emergency rooms, a couple by ER doctors, so that it does seem to be helpful. And there's even one recently that was done by the folks in England where they actually offered e-cigarettes in an emergency room. And it's published, I forget, within the last year, and they found that it was very acceptable and helped people to stop smoking. So, but whether that would be acceptable to do in a US emergency room, I'm not sure. But it always seemed to me when we were running our inpatient programs for smoking cessation is that by the time people got to the floor, they were in such bad nicotine withdrawal that they were misbehaving like crazy and often getting, other kinds of medicines to treat the behavior that other than nicotine, which is what they really needed. And we had a couple of conversations with people in the emergency room saying, what if you just slapped a patch on everybody who enrolls? And, you know, if they go home with the patch, it's not going to hurt them, even if they smoke. And if they're admitted, they'll be a lot more comfortable. So it's an idea that somebody should do.
Heard it here first.
Yeah, and I would just add to what Joanna was saying that, you know, there's so many social determinant factors. And a lot of people use the emergency room for their primary health care. So odds are an emergency room visit is going to be the way that people will get treated for tobacco because that's how they use healthcare. So I think it's an important starting point for a lot of people.
So I'm going to ask, Vermont is a place where contingency management is really a theme of the work you do, and you've really developed it. So I'm going to ask the awkward question here, which is, when you do this, I've seen lots of studies that contingency management works. I worry, and this is what I'd like to know, is how will these actually get implemented in the real world if and when they all work? It looks like they work. It looks like it's a great intervention, but the concern has always been, you know, are there additional ways or additional kinds of questions that you need to ask after they work that you could be doing to get them to actually become part of how we practice?
Steve, I'm sure you could tell us some about the successful efforts in California and several other states for what reimbursement for.
Yeah, great
incentives.
question and a long-standing challenge, and you know, something on our minds, but there's things ongoing now, mostly around psychomotor stimulant use because of the contribution it makes to fatal overdose. And so the challenge is to have it accepted as a evidence-based treatment for substance use disorders, and then CMS, either Medicaid more than Medicare, would reimburse, just like they're the ones who reimburse for, you know, counseling and motivational interviewing and that sort of thing. But mostly, a lot of it has been more, I think, the legal offices in CMS claiming that approving what I just described would contribute to fraud, increases in fraud. And the pushback is like, when is the threat of fraud new to Medicaid or Medicare? You know, so progress is being made. The biggest thing, the one that Stacey mentioned, that I think could really be influential is California, Governor Newsom, I give him credit, pushed back and said, we have a statewide crisis in fatal overdose, and we are moving forward with CM for psychomotor stimulants. And it's the only evidence-based treatment for this disorder. And we're going to do an evaluation while we do it. And so that is ongoing. Rick Rawson, who's a member, longstanding UCLA faculty member who retired back to Vermont, native Vermonter, and joined our team. He's overseeing the science of that evaluation. And it looks like it's off to a good start. And then, as is the case with lots of things in the US, the way California goes, so go other states. So other states, I'm told by Rick Rawson, are lining up to try and move in the same direction. And then one last thing is, here in Vermont, we have excellent evidence that CM for smoking cessation among pregnant women, pregnant people, increases cessation manyfold above anything else and improves birth outcomes. And so we're trying to move in the same direction as I just described for psychomotor stimulants. I think we're making progress, and there's great interest in Vermont within the Department of Health and within the offices for Medicaid to support that population. And in Vermont right now, we're using money from the opioid settlement to provide routine clinical use of CM for psychomotor stimulants. Yeah, thanks.
Another thing that I think about is how opiate treatment programs are kind of also maybe uniquely situated to, I mean, we know that there's not great substitute for high magnitude financial incentives. So, but we have a lot of like naturally occurring incentives in the clinic. So I've been part of the leadership of a methadone clinic for 20 years. And, you know, whether it's flexibility with dosing hours or a speed line, you know, where you don't have to, I mean, our patients come in every day and stand in a line of dozens and dozens for, you know, for sometimes long periods. So maybe some clinical flexibility and privileges and a fast dosing line and a close parking spot if they, you know, you could think about take homes, you know, tying some. So there are, especially in the OUD population and the opiate treatment setting, I think you could also get creative with some other sustainable and lower cost forms of incentives. You just have to, again, not repeat some errors of the past of having them be so low cost that they're ineffective. But I think we could be doing a lot more to explore some of those kind of naturally occurring incentives, contingencies as well. Another question?
Hi, thanks so much for the presentations, really interesting information. I'm not a clinician, so this question might be off base, but I have touch points with clinicians, especially clinicians in schools or in youth serving organizations. So I'm curious if contingency management is applicable or appropriate for youth or young adults, or kind of, I think the information I've seen a lot is on adults. So I'm just wondering if that's been studied, if it's relevant for youth settings or not.
Oh, so it's been widely used with adolescent and young adult populations, right? I mean, I'm thinking of presentations we were hearing the other day about other co-occurring medical problems like diabetes and management and stuff. But for smoking and drug use and alcohol, like what do we know about young? Is that what you're like the target
I know for
behaviors?
smoking, it's been used and I know, Grace, if you wanted to say more about it, but I know for smoking, it's definitely been used with adolescents, CM, and it's been shown to be effective. I don't know about the additional, you know, co-occurring use of smoking with other, but it has been shown. And I don't know, anybody who's a parent in the room probably is using CM quite often.
Constantly.
So I think it definitely has its app, you know, like I think the theory would support it. It's just, yeah, how does the school itself maybe actually implement something like that? I can't speak to that. I don't know if others could.
Does anyone else know about like use of CM for substance use or other health behaviors among young people? Like I should have more at the tip of my tongue. Yeah. Yeah. Yeah, gotcha. For what behavior? For what? Yeah. Yeah, so that's awesome. Yeah, good.
Hi, thank you all so much. I really appreciate the talk. Garrett Sang from Brown. I was interested in I believe Dr. Streck mentioned the emergency room, like you have an addiction science team, like integrated, like in emergency care. So prior to being a doctoral student, I was a pharmacy technician for 5 years and inpatient and community-based pharmacies. And when providers in the ED would provide like quick expert, a lot of the times the hospital pharmacy either didn't have an RT in stock or they were closed. And so they had to go to a 24-hour pharmacy, which does not regularly stock NRT. They can't always pull it off the shelf, and varenicline is also never stocked.
Wow.
So typically the only one available is bupropion. And what happens is what I saw for a couple of years is people would get it. We would then have to wait and fill it whenever delivery would come in, which would be a couple days. And so they wouldn't have that instant gratification. So they would lose the self-efficacy set. Yeah. Also, I did want to do a plug for Medical University of South Carolina. Mike Cummings is doing a lot of work with inpatient tobacco treatment. And then he's also we use EHR records if someone who is coded as a current smoker within 2 days, no matter where they're seen, they're being called by an in-house tobacco treatment specialist.
Oh, wow.
So really interesting work going there. Yeah.
Now, knowing what we know, to have MRT available.
It would just be demand. I think the big thing is how much are we stocking? How much are we wasting versus how much expires? And then if we can almost like an opt-out approach, give them a goodie bag at the end. Is that something that could potentially be feasible? But it's also not every ED has an addiction science team that could come in, or not every staff member would have access to that. Because NRT, even though it is an OTC, they still require a formal prescription, so it is covered under insurance. So that's another thing that they don't like forget about. So.
And some of the peer projects that we have under review, and maybe your navigator study did this as well, but we were proposing that that was part of the peer coach's role, since they are experts in navigating health systems, accessing pharmacies, finding these things. That was a barrier that we proposed that they would help overcome. But yeah, it's such an unfortunate structural barrier that is, very unfortunate.
So.
And Garrett, I don't know if you saw this in your position, but for a while, Yale-NewHaven Hospital was actually going to try to get rid of nicotine gum, because simply for the fact that when they would open a box, if a person wouldn't take all of it, they had to throw it out afterwards. And they were complaining, saying it's so expensive and we were wasting this, and they can't just sort of throw it in the trash. They have to formally dispose of it. And so I think just the way the packaging comes in is another barrier in pharmacy. Like, why can't you just have a patch in a baggie? Why do you have to open an entire patch box? And then I don't know if that was similar in your setting, but like, that's like, can't we change that?
Yeah, so a lot of the times it would just come in like the general like nicotine box. We'd slap a label on it with basic instructions that people barely read or don't read. So one thing that I have utilized is I use a lot of like graphic designs and infographics, and was creating an infographic in an opt-out goodie bag. Alana Rajeski was working with a mobile health unit and providing, it's a quick pilot study that's under publication or under review right now. And essentially the goodie bag would include an RT and like an infographic explaining like how it would work. I'm gonna have diagrams, like I included pictures, like different things to help facilitate that, especially for compensating for low literacy levels. That one didn't test for like I can't remember, I left and I ended up at Brown after, so I didn't follow up, but it's another big thing to look at. So I was like, I also don't know. And a community member, when we did have people come in for, if they just bought NRT, like at a community base, like it was at Publix or like, I'm trying to think of what's another pharmacy based like store here. Yeah. Stop and Shop. Yeah, sorry. So is they typically buy it at the pharmacy counter. Is that another opportunity for treatment? Could a pharmacist or pharmacy tech like provide that? Or like a lot of the times is I would plug in the quit line and be like, hey, like another resource is this. So yeah. Just one. I think for sure. I think if it's covered under insurance. Yeah. Because I mean, this is my thing. So another thing is like with like Stop and Shop, like pharmacy doesn't control OTC inventory. That's all front store. And so another thing would be like if they could just bring it to the counter, if the pharmacist could write the script and then slap a label on it and put it through inventory. But I don't know the logistics of that. But lots of great ideas.
Perspective though.
Yeah.
For sharing that.
Thank you all.
Yeah, so I just had a thought about your question about packaging, because we just completed a preloading study and we found the same thing. There's so much waste. You provide, the packaging, the box of lozenge or gum. They're so large and you dispense that to your participant and then they decide they like one or the other and the rest is wasted. So I was just thinking as I was sitting here and you asked that question, I wonder if there's room for like a marketplace type study where they try it right within the study session or,
Sampling.
Yeah, sampling, where they try the different products and say, okay, I'll take these two or I'll take just this one. That may avoid some of that issue. And I don't know how that could be implemented in the hospital setting or in an ED setting, but within a study setting, you could potentially do that.
Yeah, whenever we were giving out NRT for clinical trials, we would actually have people use it right then and there in the research clinic. Even just opening a nicotine lozenge canister is actually a little hard. It was like the tobacco sauce this morning. I don't know if anybody else struggled, but I did. So I think having people try it because you get past that barrier, but the impression I got from the hospital administration was that once you open up NRT in the hospital setting, unless you basically can't give the rest of that box to another patient. So you've opened up and you've given, Mr. Jones four pieces of gum and now that entire box has to be tossed. So why we can't give that out in, smaller parcels?
Yeah, absolutely.
I don't understand why we can't.
Well,
do
now
that.
like buprenorphine,
Yeah.
the film is individually packaged by dose. So, you know, there's examples of that. It's a great discussion. Any other questions or thoughts to share?
Yeah, hi. Thank you guys again so much for the talks today. I guess I just have a question specifically about e-cigarettes, because I know in the first talk today, you mentioned that youth are tending to use e-cigarettes a lot, coinciding with alcohol use, that may be increasing their alcohol use and binge drinking. But then in the talk by Dr. Streck today, there was discussion of how e-cigarettes may be used as a cessation tool. And, you know, e-cigarettes are increasing among youth, but how do we reconcile that e-cigarette use may increase the use of certain substances, but then decrease the use of combustible cigarettes and tobacco products? And I know that's it's a very loaded question, and I'm sure that future research will probably focus on that. But I guess, how do we reconcile, or maybe how do you all think about how those two ideas might conflict with each other? Thank you.
Yeah, I think that's a question of our time, right? I mean, I think in general, when we think about young people, that's the time when most people will start trying out all sorts of substances, right? And you know, a lot of people would start using tobacco products, you know, as adolescents, and then the peak onset of alcohol use disorder is actually around 18 to 25. So, and there's just a lot of data that supports that people enjoy them when they're using them together, and you can potentially not feel as drunk when you're using nicotine. So, you know, I think, so that the point I was trying to make is, like, you know, I think as young people start to use e-cigarettes, I do think that that association is going to continue. It's just going to continue with a new version of nicotine. But we also have to look at how those products are potentially being created and marketed in a way that may make them even more appealing than cigarettes, because a lot of young people have cut back on cigarettes. Do we need to necessarily have them reach these high nicotine levels? Do we necessarily need to have them in all these flavors? As somebody who works with people with cancer in a hospital setting, I definitely want these products available to help adults transition. But how do we also not necessarily make them appealing? That's why I posed at the end, can we start doing vaping bans in bars? Because, you know, the fact that smoking bans aren't even in all US states, you know, think about where young people are going to be accessing other substances, in particular with alcohol. That's a way that you can perhaps reduce you start to experiment, and then you start to become quickly addicted to nicotine. So not allowing it to be in those settings might be a way that you can protect young people, but still have those products available for adults. But you guys probably have others thoughts on that.
That's a good question. We'll still be talking about it next year at this time. When we come in 2 years. Any other questions or comments?
That was a perfect segue for the rat guy to come up and ask the question.
You have the answer.
No, it's something I've been thinking about in our studies in different ways. And you started with you talking about most of your vapors love the fruity flavors. And then you start talking about, like, you know, the fruits and the other different flavors of the pouches and everything with the alcohol. And then that question then transitioned to the uniqueness. And so I just want to hear some speculation and thinking about, because I want to think about it for our animal model work that we're doing, is there's sugary, sweet, fruity stuff in the vaping. There's sugary, fruity, sweet stuff in the alcohols. How are those going to create new, different, or continuing challenges? Just free thoughts, please go.
Yeah, I mean, they potentially going to start potentiating themselves at a level that we haven't seen, right? And you know, I was just the idea that you compare food with tobacco. You know, when patients say, well, I don't understand why after eating I want to smoke so much. Like, well, you took a reward and you made a reward sandwich. You know, you just took two really great things. And so, yeah, you take now sugary substance and you add it to, you know, alcohol, and then on top of it, you have nicotine. I mean, you just created this, like, this reward exponentially. So yeah, I think being able to understand the extent to which those flavors play a role in helping to reduce some of the aversive effects of some things and help to make you feel more stimulating effects. I mean, I think they create a minefield potentially for some of this.
And and highlight the importance, of policy, potential policy decisions related to flavored e-cigs and certain flavors.
Mhm.
Yeah.
Yeah.
Yeah. Well, this has been great. Any other questions or observations? I was trying to see, I think, lunch is at 12:30, so a few minutes away, but then, we reconvene back in this room, I think, right, Chris? For session 2, the afternoon session, which will start at 1:35. See you then.